Quick word from our sponsor, Amazon Pharmacy. We don't always appreciate what happens after we hit the sign button, getting to the pharmacy, coordinating rides, remembering one more errand after work, and caregivers are already juggling dozens of responsibilities. And that's where I think Amazon Pharmacy can help fill some gaps. They've intentionally built the experience around removing some of that friction. In your EHR, you simply search Amazon Pharmacy nationwide home delivery, send the prescription electronically, and patients receive a text guiding them through a simple and fast setup. So patients get their medications delivered fast, often same day. They have access to a licensed pharmacist 24/7, and we get to see transparent pricing upfront with eligible coupons automatically applied. I do think in terms of access, it's great that we can now ask our patients, hey, do you want this to be sent to your local pharmacy, or would home delivery make life easier? We'll link more about Amazon Pharmacy in the show notes, or you can visit pharmacy.amazon.com/prescribers. Here at Corium, we're talking about the real things that can help anyone who works in healthcare. And today we're talking about how the scrubs you wear, they can make a difference. I remember the first time I saw one of my colleagues walking into a sign-out room looking way more put together after a night shift. And I knew right then and there, they were wearing FIGS. FIGS Scrubs is made specifically for us, doctors, residents, students, healthcare professionals who are putting in long hours and really need gear that can keep up and perform on our level. We have so much going on in any shift, right? Scrubs are the last thing we want to be thinking about. And that's why FIGS is great in that they're lightweight, stretchy, breathable. They have all the small touches that have made me a true convert. They're clean, they're modern, super functional, tons of pockets that I love for all the snacks, zippers that don't snag, and antimicrobial fabric to stay healthy while working. You deserve better scrubs. You deserve FIGS. So head over to figs.com and enter FIGSRX at the checkout for 15% off your first purchase. That's figs.com, promo code FIGSRX for 15% off your first purchase. And with that, let's head back to the episode.
Hi, everybody. I'm Ari Fish. I'm a chief resident at Mount Sinai Hospital in New York City. And I'm really excited today to be joining Corium to dive into the 2026 ACC/AHA Lipid Guidelines that just came out. I'm thrilled right now to be joined by two frontline primary care experts who can guide us a little bit more on cholesterol management based on these guidelines. So without further ado, I'd like to introduce some of our panelists. I am very excited to be joined today by Carrie and Alana.
Thanks so much, Ari, for that wonderful introduction to the show. I'm Carrie Blum. I'm a primary care doctor at Mount Sinai. I work with Ari. I'm also a lipid enthusiast who spends a fair amount of time thinking about this stuff.
And I'm Alana Richmond. I'm a primary care doctor and general internist at the Yale School of Medicine. So happy to be here with you both. And like Carrie, I'm not a cardiologist, but I am a lipid enthusiast and also have spent some time trying to wrap my mind around the guidelines. So excited to dig in today.
All right, Carrie, Alana, let's get going with the top 10 practice-changing highlights from these new lipid guidelines. So where should we begin?
All right, so let's get started with the top 2 practice-changing highlights. I think it's helpful to start with the new framework suggested by the guidelines, which is summarized into a 3-letter acronym, CPR. Have you heard that one before, guys? CPR?
Maybe a different CPR.
Yeah, not cardiopulmonary resuscitation. This is the one that's happening all the way at the beginning of when we're starting to think about our patients' cardiovascular health. This one stands for Calculate, Personalize, Reclassify, and essentially describes a general approach to identifying patients' risk and deciding a management strategy based on that risk calculation. So for the C, that stands for Calculate, we're using a new calculator called the PREVENT score. The PREVENT score has replaced the old pooled cohort equations. It uses slightly different variables, but essentially most of the old ones like blood pressure. But now we're also able to add additional things like GFR and proteinuria and geographical risk factors based on zip code. So the PREVENT score really is an improvement on the pooled cohort equations in terms of identifying a more precise risk. But then the framework goes even further to suggest that once we use the calculator, we are not done. We have to really think about our patient as an individual and whether or not the calculator has done them justice. This involves primarily a thought process about any risk-enhancing factors that may be present. And then last but not least is this reclassify step, where you're putting the Personalize data together with the calculator and coming to a final decision. And if you're not able to come to a clear decision, sometimes ordering additional testing, such as coronary artery calcium, can help be a tiebreaker when you're trying to decide whether a patient may benefit from lipid-lowering therapy. So those are the first two big takeaway points. This new framework is the CPR framework, and our new calculator, the PREVENT score, which has replaced the pooled cohort equation.
All right. So point number 3 in our top 10 list is that we have somewhat different risk categories than we saw under the last set of guidelines. So in the last iteration of the guidelines, we were accustomed to calculating a person's 10-year ASCVD risk and then recommending or considering statin therapy based on that risk. But it was known that the pooled cohort equations overestimated risk. And so in considering the threshold to start a statin, for example, the guideline authors used a slightly higher threshold than actual risk, understanding that pooled cohort equations slightly overestimated. So in this iteration, those thresholds are lowered because the PREVENT equations are better calibrated and really reflect actual absolute risk. Just to be sort of explicit about what those thresholds are, a 10-year risk lower than 3% is considered low risk. And in general, for primary prevention, we don't necessarily need to start a statin absent a few other considerations. The next category is called borderline. So those are people with a 10-year risk of 3 to 5%. These are people where we consider risk-enhancing factors that Carrie referred to. So these are the ones where we really are strongly thinking about that reclassification idea. And then the 5 to 10% are intermediate risk folks. Generally, we would recommend a statin, although we can use CAC in this category to reclassify. And then more than 10% is high risk. So the framework is, those numbers are sort of shifted down from what we might recognize from the previous iteration of the guidelines, but are really actually meant to represent similar categories of risk.
Okay, so just to recap where we are so far, we've introduced the CPR framework, calculate, personalize, and reclassify. And we also introduced that new PREVENT calculator, which replaces the pooled cohort equation and adds more individualized inputs like kidney function and even social factors like zip code. We also reviewed the updated risk categories, low, borderline, intermediate, and high risk, and how those thresholds are slightly lower than in prior guidelines, but really just better reflect true absolute risk. Okay, I think I've got it. Let's keep it going.
All right. Our fourth highlight is that LDL targets are back. So in the last version of the guidelines, 2 guidelines ago, we had LDL targets. Then we shifted away from them in primary prevention with a focus on starting a statin of the correct intensity and dosing. Now we're back to LDL targets. So what are they? So the guidelines say that for people at borderline or intermediate risk, so that 10-year PREVENT score of 3 to 10% basically, we would recommend an LDL target of less than 100. Along with that, there's also a recommendation to lower the LDL by about 30 to 49% from the baseline. For people at high risk in a primary prevention category, and for some secondary prevention patients, a target of less than 70 for the LDL is recommended. And then for those at very elevated risk, people, for example, who've had an event, so secondary prevention and have ongoing risk factors, an LDL target of less than 55 is recommended. One thing I'll say about these absolute targets is that as a practicing clinician, they're easy to kind of hang on to. Like they stick in your mind. When you're counseling patients or thinking about whether we need to intensify therapy, they're just a lot easier to remember than trying to calculate the relative reduction in the LDL from their baseline and going back through the chart. So, whether this is sort of the optimal approach in terms of the data and all the rest is an important question, but I think from a pragmatic standpoint, it makes a lot of sense.
I love it. I agree. I mean, I think it's our approach for many other chronic diseases like blood pressure. We create a goal. Diabetes, we make an A1C goal. And now with hyperlipidemia, we can kind of be in the same ballpark of thought process. So for our fifth practice-changing highlight, I want to talk about those populations of folks for whom the calculator may not be as relevant, because there are some patients that have elevated risk just by virtue of having certain comorbidities. And in this particular new iteration of the guidelines, patients with chronic kidney disease and HIV have now been included, along with patients who have diabetes or very elevated LDL. as folks for whom lipid-lowering therapy should be strongly considered regardless of their 10-year prevent risk. Just to be a little bit more precise, patients with CKD stage 3 or higher, so that would be an eGFR of 60 or lower, should be on at least that intermediate risk algorithm that Ilana just mentioned. You could also use the prevent score to identify if they may benefit from an even more intensive strategy. And then also people living with HIV were recently showed, even in a low risk cohort, to benefit from statin therapy in the Reproductive trial. That's been incorporated now into the new guidelines. So I love this because it's simple. We don't have to go through the calculator. So just by virtue of having either eGFR of 60 or lower, your HIV, at a minimum, that would put your patient onto that intermediate risk pathway where you're targeting an LDL goal of less than 100.
All right. Practice changing highlight number 6 is lipoprotein(a) screening for everyone. So this, I think, actually really does feel like a big shift from previous guidelines. So in the past, lipoprotein(a) testing was sort of optional and recommended as something we could evaluate as a risk-enhancing factor. But here we're seeing a stronger recommendation for screening for everyone. Lipoprotein(a) has some interesting features. It's largely genetically determined. It does not necessarily correlate with other lipids, so with LDL, and can really identify this other dimension of risk that can be sort of hiding in the background unless we specifically check for it. We don't at this time have medications that directly lower lipoprotein(a) on the market, although many are in development and in trials, and I think we'll see treatments for lipoprotein(a) in the next couple of years. But in the meantime, our approach is really thinking about how elevated lipoprotein(a) changes our approach to global cardiovascular risk reduction. So these are patients in whom we might think about intensification of therapy or even use of a PCSK9, which secondarily can lower lipoprotein(a) by maybe 10 or 20%. So I think we'll really start to become more comfortable with ordering and interpreting lipoprotein(a), and it's a way in which I think the guidelines have really sort of shifted and changed from the previous version.
Absolutely. I couldn't agree more, Ilana. For me, over the past month, I've been checking a lot more lipoprotein(a)s, and it is an important risk factor. Values of 250 double one's lifetime risk of experiencing an ASCVD event, and values of about 125 increase one's lifetime risk by 40% compared to patients with regular Lp(a) levels. So it's a very important risk factor that's often hiding in the background and will not be uncovered unless you check for it.
So, Carrie, I'm just thinking a little bit about from a resident perspective, when we have a new patient in clinic and we're getting baseline labs, do you feel like in addition to getting hemoglobin A1C, lipid panel, and understanding a little bit more about their baseline, would these new guidelines indicate that maybe adding an Lp(a) for any new patient coming into clinic would be appropriate?
Generally, yes. And for me, that's kind of crept into my practice. One thing that's been annoying is for me, the Lp(a) takes way longer to come back than the rest of the labs. So I've found that it's actually really important to communicate with the patient about this particular test before you order it, to let them know what you're checking for, that it's going to take a little bit longer to come back, and how, if it's elevated, that may impact your outlook on their risk. Because for a young patient without other risk factors, if you plug them into the prevent and their 10-year risk is 0.5%, a slightly elevated Lp(a) is probably not going to make me put them on a statin, but it might be helpful for them to know that that's a risk factor that they're likely to have for the rest of their life. And as they get older and maybe accumulate additional risk factors, it may lower the threshold to think about lipid-lowering therapy. And it may provide additional motivating factors for getting into a healthy cardiovascular lifestyle. So I think in general, by default, it's a good test to order. So our 7th big practice-changing highlight from the new guidelines is the use of apolipoprotein B testing as an adjunct to LDL cholesterol and other measures of lipoprotein-mediated risk. So as we've done for many, many decades, and as we've done so far in this podcast, we've discussed LDL cholesterol as the primary biomarker that we're using to assess cholesterol-mediated risk and assess treatment response. The sad reality is that LDL cholesterol is the one we know about best, but it's not the one that we know works the best. Apolipoprotein B is more precise for an average patient. And there tends to be a certain subpopulation for whom the LDL cholesterol does not work as well and will under-risk your patient. That tends to be patients who have high insulin resistance levels. So they may have diabetes, they may have elevated triglycerides, or an unusually low looking LDL cholesterol. Those are folks in whom checking an ApoB may help identify that subpopulation that would benefit from additional, more intensive treatment.
Thanks, Carrie. And just a quick reminder for those who'd like to dive in a bit deeper to Lp(a) and apolipoprotein B. There's an excellent Core IM 5 Pearls episode reviewing this topic much more in depth. So be sure to take a listen if you have a minute.
All right. So our 8th practice-changing highlight, again, gets at this idea of risk reclassification. The guidelines now identify an expanded set of reproductive risk-enhancing factors. So these include things like PCOS and premature menopause, which is defined as menopause younger than age 45, and also a number of conditions that can arise during pregnancy. This includes things like gestational hypertension, but also preeclampsia, having a baby that's small for gestational age, and gestational diabetes. So in the last probably 20 years, all these things have been recognized to confer long-lasting cardiovascular disease risk, and we're increasingly thinking about identifying these in our patients.
So I think this is quite interesting and would absolutely change my management, especially if we have a new patient coming in. I don't always naturally think to talk to them about issues that they went through during their pregnancy, especially if that was 20, 30 years prior.
Ari, point well taken. If we're seeing a 65-year-old woman, we're not necessarily taking a really in-depth OB history. But the way I think about this is that pregnancy involves a lot of additional physiologic stress from the standpoint of vascular health and insulin sensitivity, and essentially gives you a little bit of a glimpse of what might happen if your patient were to undergo like a stress test almost in a way, right? Like it's a physiologic stress test. So a lot of risk factors that may become relevant later in the patient's life could get uncovered during this very important period of time.
Just to tie this together, next time I'm in clinic, I'm really going to lean into that P of CPR, personalize, by asking, if appropriate, questions about reproductive history, like premature menopause, gestational diabetes, preeclampsia. And I think, it's a good reminder for me that risk isn't just about what's in these calculators, but also what we can uncover during our in-depth discussions with patients.
So let's move on to our 9th practice-changing highlight. This is involving coronary artery calcium, also known as CAC. CAC scoring is something that we've known about for years, but we really are only starting to become more comfortable with in clinical practice. What is it? Well, basically, you get this score whenever somebody has a non-con chest CT. Sometimes it's a dedicated one, which is specifically looking for coronary artery calcium. And in that case, you get a score, which is called an Agatston score. But what it is essentially a calculation of the surface area of calcium that's present in coronary arteries. And we know that if there's more calcium, there's more plaque. And if there's more plaque, there's more probability of any one of those plaques rupturing. And so quantifying the total amount of plaque can be helpful in helping to make risk more precise. The new guidelines give us more guidance than the old ones do, but it's still essentially used in the same way. So the old guidelines suggested that in patients who have either a borderline or intermediate risk prediction from the calculator, you may decide to order a CAC score as an additional data point to help make the risk estimate more precise, so that patients without any CAC potentially could stay off of lipid-lowering therapy, whereas the presence of coronary artery calcium generally would be an indication for therapy. But that's kind of where they stopped, and the new guidelines are now expanding upon that to give us more guidelines in terms of exactly how much CAC should correlate with what treatment strategy. So we still understand that having no coronary artery calcium in intermediate risk patients who are 50 or older essentially predicts no additional benefit from statin therapy. Whereas once your CAC score is 1 or greater, you start to see the curves separate a bit and lipid-lowering therapy is beneficial. The new guidelines suggest that CAC scores of 100 or greater should be treated more intensely. The other great thing that the guidelines do is now give us a little bit more of an idea of what to do with results that we weren't expecting. So the classic case there is lung cancer screening. occasionally you'll see a result come back with moderate to severe visual coronary artery calcium. Those patients generally should be treated on the high risk pathway, LDL less than 70. Or if it's more of a mild CAC picture, you could probably get away with more of the intermediate risk strategy of less than 100.
I think there's a lot of discussion about this idea of downgrading risk in people in that intermediate range. And is that really valuable, given that we know that statins are generally safe and well tolerated? But I will say that it's not unusual for people not to want to take medications, right? Like, who wants to take a medication? I can totally relate to that idea. And so for a subset of people who really would like to avoid medication, this does help us, I think, reclassify which patients can safely hold off on a statin versus those that really ought to be on it.
So Karen, Alana, would you say that the CAC can really be used as a tiebreaker when we're looking from a perspective of primary prevention in this intermediate risk category to help us guide our statin decision-making?
Yeah, the best use case for CAC is in intermediate risk patients who are older than 45 to 50, so have had at least that amount of time to calcify if they're going to calcify, when you basically need a tiebreaker, just like you said, Ari. It's a great way of putting it.
All right. And then rounding out our top 10 with number 10 for our practice-changing highlight, the role of non-statin medications. So the guidelines call for the expanded use of non-statin medications in primary prevention when we're trying to meet those LDL goals. And I would say even before these guidelines, I've seen increasing use of non-statin medications like ezetimibe to try to drive down the LDL. The guidelines also talk about using other medications for primary prevention, including PCSK9 inhibitors and bempedoic acid. So all these are options depending on the clinical context and the person's risk for achieving those LDL goals. The guidelines importantly recommend against using quote-unquote dietary supplements. I think this is really meant to refer to things like over-the-counter fish oil. Over-the-counter fish oil is distinct from prescription-grade fish oil, which is highly refined, for example, icosapent ethyl, which has some data around its efficacy for cardiovascular risk reduction. Over-the-counter fish oil, not effective, along with a host of other kinds of supplements that patients often turn to because of claims around cardiovascular risk reduction. So I think we can clearly counsel patients that these are not recommended, not effective. And of course, any over-the-counter supplement is not regulated in the same way as a pharmaceutical product by the FDA and has generally unknown risks, potency, purity, and all the rest. I'll also add that I practice in a federally qualified health center where many of our patients are low income. And I'm often shocked by patients who come into clinic with a plastic bag full of supplements that are really expensive. And I really hold the industry accountable for the claims that they make and the way in which these supplements are marketed toward patients. These people end up spending a lot of money on things that they are hopeful will be helpful, but I don't think the evidence is there, nor are the products regulated. And so I really try to steer my patients away from it, often in part because I think it's basically a waste of their money.
I think that's a huge point, Ilana, that a lot of patients don't really realize. If you're buying something from a pharmacy that comes in a bottle, it seems pretty legit. And I think that, discussing that with patients can be a really important moment. I often will use this as sort of a way to segue back into a discussion about lifestyle, because often when there's an aversion to medication and more acceptance of supplements, that may be a patient who may be more amenable to conversations about healthy eating and ways that they could shift their diet around. So that may be a good direction to steer things in if questions about fish oil come up.
All right, lipid lovers, those are your top 10 practice-changing highlights from the 2026 ACC AHA Lipid Guidelines. So let's do a quick recap just to close this out and go over what we learned today. So we started by learning to use the CPR framework that calculate, personalize, and reclassify. We calculate specifically using the new PREVENT calculator, which replaces the pooled cohort equation. Then we'll personalize and reclassify when appropriate. We learned that LDL targets are back and they're used in conjunction with percent LDL reduction depending on our patient risk factors to risk stratify. And remember those high-risk groups we learned about today, especially advanced CKD and HIV patients. We are now going to check an Lp(a) once in all adults, and we'll also use apolipoprotein B when we're concerned about any type of residual risk. And don't forget about those expanded risk enhancers, especially getting a thorough reproductive history on the appropriate patients. We learn to use our CAC score to help refine our decision-making, but really not to override any clear risk. And finally, we're going to escalate therapy when needed, especially with non-statin medications, but we'll skip those supplements that really just don't have the evidence to back them up. So huge thanks to CoreIM and to Carrie and Alana for joining. And be sure to join us for part 2 of this lipid series, where we'll walk through cases and really try to dig into exactly how to apply these guidelines in practice. Until next time.
What about non-statin drugs, Ilana?
Perfect segue.
Dietary supplements.
What about diet?
Most people don't realize how much their personal information is being bought and sold every day. Data brokers are making billions, pulling details about you from public records and the internet, and then packaging and selling it, usually without your consent. That's how your information lands in the hands of scammers, spammers, even stalkers. It's why you get endless robocalls and why ads seem to follow you everywhere. That's where Aura comes in. Aura actively removes your data from broker sites and keeps it off. They also instantly alert you if your information shows up in a breach or on the dark web. But Aura goes beyond data protection. With one app, you get a VPN, antivirus, password manager, spam call protection, dark web monitoring, and even up to $5 million in identity theft insurance, all backed by 24/7 US-based fraud support. Other companies might sell just credit monitoring or just a VPN. Aura gives you all of it, together, at the same price competitors charge for just one service. Start your free trial today at aura.com/remove. Protect yourself now at aura.com/remove.